So this is a 15-year-old male who presented with history of right knee pain and swelling for 10 years. The history was atypical for chronic arthritis, as the swelling was episodic, with the swelling occurring only every few months and typically lasting less than a week. Between the episodes, his knee felt completely normal. When he was seen at his first visit, he had arthritis in the right knee that was confirmed by ultrasound. No fever or other positive findings. Normal X-ray and lab studies including CBC, inflammatory markers, GC, LAM, rheumatoid factor, and high CCP, and HLA-B27. The long duration does not support infectious cause. He was otherwise healthy without systemic rheumatology conditions. Joint aspiration revealed zero sanguineous fluid from the joint. Steroid injection was performed. At that time, the preliminary diagnosis was juvenile idiopathic arthritis, although his cause was quite atypical. 6 months later, he returned to clinic with another episode of right knee pain and swelling again. This time, the bedside ultrasound revealed an increase in Doppler signal within Hoffa fat pad, which I think is not a typical site for synovitis in JIA. We proceed with an MRI of the knee, and it showed a 4 cm mass within Hoffa fat pad. The mass had multilocular with septate appearance and contrast enhancement. The image was consistent with synovial hemangioma, a rare benign tumor. He was referred to orthopedics, had an arthroscopic excision of the mass and synovectomy. The diagnosis was confirmed on histopathology. His off and on knee swelling could be explained by episodic intra-articular bleeding and hemosiderotic synovitis. This case emphasized that JIA is a diagnosis of exclusion. Therefore, it is important to be aware of other etiology for joint pain and have a broad differential for arthritis in children.